And then it's my pleasure to introduce Helmut Baumgartner. We all know that he's an expert in congenital heart disease, also in valvular disease. He already did the last decades a lot for the GUCH community. Many thanks for that. But now you may present something in between the low gradient pulmonary stenosis in repaired fallow factor fiction.
Thank you, Werner. Judith, ladies and gentlemen. May I first ask you, who of you has read a paper on low flow, low gradient pulmonary stenosis? It makes me feel better because I had a hard time to find literature on that and to find out what I can talk about here. Well, we all know that wherever we have a flow obstruction in the circulation, the velocity or the gradient across this obstruction will not only depend on how tight this obstruction is, it will also depend how much flow goes over this area. Now, this is a very old diagram from a textbook showing the relation between cardiac output and mean gradient for aortic stenosis, nicely demonstrating that in a patient even with severe aortic stenosis, if for any reason the patient has an abnormally low flow, the gradient may be lower than expected. And this is an important message. And for many years, we all have requested that when we assess aortic stenosis, we not only want to know the velocity, the gradient, we always want to know the valve area, and in the new recommendations, the flow, some idea at least of the flow across the valve and the ejection fraction. Now, how about pulmonary stenosis? I feel bad that I'm also responsible for this paper published in 2009, where we first made the recommendations for stenosis assessment, and we could say very little about pulmonary stenosis because of the lack of data. So you see what we said is that quantitative assessment of pulmonary stenosis severity is based mainly on the gradient. And actually, we had to admit that we have no validated ways to calculate pulmonary valve area and no idea how to interpret such measurements, which are normally not taken. Now, and ending up with only saying that mild, moderate, severe aortic stenosis is determined by these velocities and gradients. Now, this was several years ago. I tried to look at the literature and thought maybe the pediatric cardiologists are more aware of this problem. And this is the most recent review I found. This was just e-published in March. And again, what they say is transvalvular Doppler gradients is in general used to classify the severity of pulmonary stenosis, only talk about correlation to catheterization, and end up with the comment that their analysis revealed marked heterogeneity in the classification of pulmonary stenosis severity from Doppler gradients, especially in mild to moderate forms. When we look at the guidelines, there's only one comment we made that makes us aware of the problem. For the recommendations of intervention in the right ventricular outflow tract obstruction, you can see that there is a 2A recommendation that intervention should even be considered with a gradient lower than 64 millimeters mercury in patients who have a decreased right ventricular function. Again, being not more specific because there was no data to be more specific in the guidelines. Now, does that mean this is not an issue? Nobody appears to be interested in that. Well, let me share with you this patient here. A now 32-year-old female born in 1985 with tetralogy. She received a PT shunt when she was 5 years, and at 6 years she had a repair with a transannular patch. In 2002, now 17 years old, because she had severe pulmonary regurgitation, she was reoperated with a Condeco graft. And in 2007, still in pediatric care, she is reported to have a balloon valvotomy because of a suspected xenograft stenosis. In 2009, she was successfully resuscitated, received an ICD, and during the same year later, VT ablation. Now, when she presented to us in 2013, she had a recent clear decrease in exercise capacity. That's what she reported. She had 4 adequate ICD shocks since 2009, and with the ECD, it was possible to actually look at the arrhythmia frequency, and there was a documented increase in arrhythmias recently. By exercise testing, she had a moderately decreased exercise capacity, 75% of expected, and a decreased VO2 max with 69% of expected. And she had a markedly elevated NT-proBNP with 1,800. So this is her echocardiogram, and it shows the peak velocity across the contago graph. This is already the highest velocity. There were velocities between 3.1 and 3.5 meters per second. By definition, it would be a moderate obstruction of this contago valve, but you see on the right-hand side that her right ventricle is clearly poorly functioning. Without giving you any numbers, I think everybody agrees that there's a marked decrease in the right ventricular ejection fraction. So one would suspect that there may be a low flow, and how can we deal with that? Now, in aortic stenosis, we have hundreds of papers dealing with low gradient aortic stenosis by now, and still a lot of confusion. I think everybody is struggling with that, and we just published European and North American recommendation paper on that. And what we recommended now is that when we see a patient with a low gradient and we have the suspicion of significant aortic stenosis, the next step would be to calculate the aortic valve area. When the aortic valve area is larger than 1.0 centimeters square, we would consider this is moderate stenosis. But if it's less, this is a really difficult situation, because it means that the patient could have severe aortic stenosis, but many of them will not have severe stenosis, and it requires a very careful exclusion of measurement areas which tend to underestimate the flow and therefore the valve area. And when we are still sure that the valve area is small, the next step would be to define the stroke volume index. If we have really a low flow situation, we would go on. If we have a normal flow situation, we would rather see it's unlikely that the patient has severe stenosis. And if we have a low stroke volume, the next step would be, is it a low ejection fraction or a preserved ejection fraction? If it's a low ejection fraction, we do the butamine echo. If there's flow reserve, we can distinguish between pseudo-severe and true severe. If there's no flow reserve, or if we have preserved ejection fraction, these are the most difficult patients, and what is recommended is to use an integrated approach with a number of clinical, qualitative and quantitative measurements, including calcium score, to find out whether the patient has severe stenosis or not. Now, how are we dealing with the problem in pulmonary stenosis? Well, as I said, they did techniques to measure valve area to begin with. We have no validated techniques to measure the true flow across the valve. There are major limitations to assess echocardiographically right ventricular function. Gold standard is CMR, but in a patient with an ICD, as I just have shown you, we can't use CMR. And what do we know about right ventricular contractile reserve? Well, there are indeed several papers that dealt with contractile reserve of the right ventricle in patients after repair of tetralogy. They used either exercise or the butamine stress. When they used echocardiography, they used the tissue Doppler imaging indices, TAPSE or fractional area change to calculate changes with increasing flow. And by CMR, it's in general right ventricular volumes and ejection fraction. But these papers, more or less, they compare to healthy controls to see whether these patients have a different contractile reserve, looked whether it's a predictor of exercise capacity or outcome or early detection of RV dysfunction. So no really mention of what happened to gradients or to right ventricular pressure. There's only this most recent paper where one can see that something happened to the pressures when they did these kind of stress echoes. They did here exercise echocardiography and calculated the fractional area change. And if there was a positive change, this was a responder. And if it was a negative response, it was a non-responder. And the main findings was that this was somehow predictive of further events. And when you look at the data, there was an increase in RV pressure, but it was an increase in both groups, the responders and the non-responders. But at least it may tell us that we should look more closely at stressing these patients to find out about contractile reserve and further classify the severity of the stenosis. Now, without having any evidence and having no data, we were actually convinced in this patient that the obstruction of the contagious graft is a problem, and we, after pre-stenting, implanted a melody valve, and with getting rid of the gradient, peak velocity was slightly below 2.0 meters per second after the intervention. This was the result. You can, again, without needing to calculate something, I think it's clear that the right ventricle has remodeled. It is smaller now, and the right ventricular function is better. Unfortunately, left ventricular function is still not normal and did not recover. Now, this was the course of the patient after this intervention. There was some improvement in exercise capacity, almost what one would expect in such a patient. Less documented arrhythmias. NT-proBNP went significantly down, but still elevated, and left ventricular function was still reduced. Very good function of the new valve, and this was stable now for 3 years. So I think, at least from the course, one can say that we did probably the right thing in the patient. So what is my conclusion? Well, I think low flow, low gradient pulmonary stenosis and repaired tetralogy of Fallot is definitely a fact and not a fiction. The problem is that it's almost not studied yet. So I would like to stimulate Louis to study this in more detail. Low flow that may result in a low gradient despite severe right ventricular outflow tract obstruction may primarily be due to right ventricular dysfunction, but also to associated severe tricuspid regurgitation. Exercise or determined stress may be used to increase flow and to study the gradient response, but it needs further research to know how to interpret that. So my main conclusion is that further research is required to help us identifying severe pulmonary stenosis in case of a low gradient. And before I end, I would actually like to take the opportunity to remind you that next year, EuroGUCH will be in Münster, and we already want you to save the date. It's 20 to 21st April 2018. And what is special, it will be a joint session, a joint meeting of EuroGUCH and the 11th Advanced Symposium on Congenital Heart Disease in Adults. And we hope that we can all welcome you there next year. Thank you very much.
Thank you for your excellent and difficult talk. I have to admit that we don't have any documentation for the talk as you demonstrated. Do we have any questions?
Antonio Corno, Leicester, UK. I'm a very simple-minded surgeon, but if you have a patient with low flow, low gradient, an indirect sign of right ventricular function, why we cannot use the evaluation of the flow on the aortic valve? If the patient doesn't have any intracardiac or extracardiac shunt, we speculate then the flow through the aortic valve should be the same than the flow through the pulmonary valve. It makes sense?
This makes sense if you have no pulmonary regurgitation, because you only know the net flow, and if there's no shunt. So in this situation, this could help you to calculate
but
the flow.
You are very good in calculating the quarter regurgitation by non-invasive method. So if you have non-invasive measurement of the systemic flow, and therefore the pulmonary flow should be this one, you can eliminate the quote lost by regurgitation.
But as I said, in many patients you have a combined problem, and not only stenosis, but also regurgitation.
But you can calculate the regurgitation fraction, right?
I agree that you can, yeah, well, by echo this is also not really accurate. MRI would probably be the best if you want to get an idea of the flow across the valve and to assess whether it's really a low flow situation.
So you can non-invasively calculate the pulmonary flow?
By MRI, yeah. But nobody does it in this question. This was the point what I wanted to make.
You can always start and be the first.
Yeah, that's why I try to stimulate you to further study this issue.
Can I address Corno's question? Many times these patients are very complex patients, and also if we want to calculate the flow in aortic flow and pulmonary flow, we have to exclude the aortopulmonary collateral flow that many times it exists in that patient. So it's possible, but not quite simple.
Yeah, it's not simple, and it requires to consider a lot of aspects in these patients.
Do we have question in the Olympia room?
There are no questions. Thank you.